So
Hello
guys,
and welcome to episode 4 of Isokinetics 101. My name is Rob Potash with CSMI, the sponsor of Isokinetics 101. Isokinetics 101 is a free monthly webinar brought to you on the third Thursday of each month. The goal of Isokinetics 101 is to help educate clinicians how to use an isokinetic machine in the clinic and in the training room for testing and exercise. Our content is new and provided by John Hisamoto of Proactive Physical Therapy, Tampa, Florida, and Daniel Bodkin, currently in transition from Nashville to Atlanta. The webinars are live, and it is time for John to come aboard. John?
thanks, Rob. That was really good. You've practiced that a lot since the very first time. I can tell. You sound so good at doing that. I'm going to knock this out. I'm going to ask you guys to knock yours out too, so we can get to the screen. And so today we're going to really kind of talk about the isometric component. And Daniel, I want to kind of keep you on here for just a little bit, but really talk about the isometric training and program that we're going to be going through. So, and Daniel's done a great video that we're going to be sharing with you at the very end. But we want to make sure that we're also meeting some of the needs that you guys have. Any of the concerns, any of the questions that you have, we want those to kind of come back to us so that we can address those questions and make sure that we're continuing to make this an effective training webinar series for you. So again, in the future, what we want to be able to do is to get after some of those discussion points that you're interested in. So today it's about stabilization, and that really kind of helps us go through those modes of rehabilitation that we talked about. We want to talk about mobility, which we equate to passive. We want to talk about stability, which is great for isometric. We want to talk about strength, which is isokinetics, and we want to talk about control with isotonics and why each one of those kind of fits those modes. We want to go behind the exercise and look at the science and some of the rehab concepts that we have come up with that we can share with you, but we'd love to have you come back and share with us also. So here's one of the things that I want to ask you to kind of let us know. Send this through, Rob. Are you guys interested in a users meeting early on in 2020? So we kind of put all of these concepts together that we've been talking about, and we do hands-on training for a couple of days so that you come in, you go through each one of these programs, and you come away with a certification as an isokinetic specialist as level 1. In the future, we're going to be talking about isokinetic testing and training and eccentric loading and deceleration training, which is the new isokinetic training programs that we've come up with to kind of help us kind of reach back to functional types of rehabilitation programs that we need to go to. So those are the points that we're interested in presenting with you, and we want to make sure that you guys are too. If you need CEUs, we're interested in providing those in the future. So if that's something that will kind of keep you a little more tuned in, we'd love to know about it also. So again, we get back to that really beginning point that we had. Is it a stability or a mobility problem? Now, Daniel did a great job last month talking about mobility and passive exercise and ways that we can use passive. And we need to emphasize joint and soft tissue mobility. And I often do this with a lot of my students. It's like, is it only joint mobility issues that we're having? Everybody wants to go in and joint mobilize, but there's a lot of soft tissue issues that we have. And so we might need to get into instrument-assisted soft tissue mobilization. And and he showed you great techniques with hawk grips that we've used in the past. Well, how about skin and scar? We know that it happens a lot. You see it with your total knees. We'll talk about that a little bit tonight. But most of what we're going to be talking about is stability. How do we emphasize strength? That stability, the motor control aspect of getting into force production. Now we've got to be able to get a little bit stronger and a little more stable in some of the things that we're doing to be able to be functional in our rehabilitation. Now, Daniel also mentioned that I was big on some of the things that I call pearls, and those were our proactive pearls. Those were the little things that we used when we talked to students or new users, or we hosted several different therapists from the United States and different countries, and we always gave them little key pearls to take home with them. And he mentioned this one last time, but I really want to kind of go back over and make sure that we go from the very beginning to the very end. So when I talk about setups, I always talk about setting the patient from a proximal to distal alignment. And really what that means is if someone's sitting, you want to look at their alignment of their back and pelvis first, and then their hip position, and then their thigh length. Then you want to look at the knee. So that's when we're going to adjust the axis of rotation, the axis of rotation. And then finally, we're going to adjust the pad to where it should be placed on the tibia. Some people think, 2 to 3 finger breadths above the medial malleoli or 5 centimeters above the medial malleoli is a great position. Others believe that we can change that to kind of go up or down depending on the amount of stress that we want. And we'll talk about that a little bit also. And then finally, what I say before we ever attach them is we want to take them up and down through the range of motion, and we want to kind of measure that there's no pivoting, that the pad isn't sliding up and down on the tibia, because if we have the axis of rotation correct, then we know that we're going to have the alignment and everything else is going to be appropriate. So Pearl 1 is always kind of make sure that we're setting the patient from proximal to distal from an alignment standpoint. Pearl 2 is, and Daniel mentioned this also last time, I like to see all of my students and any of my new users do at least 10 setups from start to finish before really applying to patients. Now, that doesn't mean that you can't adjust something for the patient that you're going through, but if you're going to be doing some testing or some training, you really want to have that familiarity with the machine and the setups so that you know what you're going to be doing with your patient. Because patients do get concerned when they see the therapist seems to be a little unsure. So, how are you setting them up and what are you trying to do with them is really what we're really talking about. So, do that 10 setup from start to finish to make sure that you feel very comfortable. What I normally see with a lot of my students is, they start off 1, 2, they make a mistake early on in the software. They get to 3 to 4, they're going through the software, now they're aligning incorrectly. We get to 6, 7, they've gone through software, they've gone through alignment, now they're starting to attach them to the position, but do they set up the start and end positions correctly? By the time they get to 8 or 9, they're doing everything correctly, and at 10, they feel very confident in what they're able to do. And Pearl 3 for me is always use visual feedback, and we'll talk about this a little bit more, but it's to teach the progression. It's really to guide the patient correctly. So if we want them to give us 25% of their effort, we want to use the screen to kind of show them how much force they're generating and that it's not oscillating, that you don't see it just kind of pivoting up and down, but they were actually holding it fairly steady. And there's different screens that we can use to kind of give them better visual feedback. But the visual feedback, I think, becomes very important. And then when we're starting to talk to the patient, early on, I don't mind aligning 0 pounds to 0 pressure, 10 pounds to 10%, 20 pounds to 20%. But what I'll do is I'll have them push with 5 pounds of pressure in the very beginning. And I'll ask that individual patient, how much effort are you giving me? And I use that as my control guide to how far I'm going to take it. So if they're giving me 5 pounds and I've got somebody fairly strong and they're like, that's less than 10%, I know that I can take them up to 25, 30 pounds fairly comfortably at 50%. But if I have somebody else on there that feels a little more timid or they're having some control issues and they tell me they're already at 50%, I'm not going any further. In fact, I may even back it off just a little bit and go to 3 to 4 pounds to make sure that they're going to be very comfortable in everything that we're doing and that they're holding that force for the period of time that we want them to. Could be 3 seconds, could be 5 seconds, could be even longer, okay? So Pearl number 4 for me is always this, and that is speed kills. Early on in isokinetics, it seemed that speed was the thing that everybody wanted to get to. They wanted to go faster and faster. And if you remember in the very first discussion, we alluded to this, is that speed isn't the only parameter that we need to look at. And we're really going to get into this next month, but we need to also pay attention to the range of motion associated with speed, because that's going to tell us whether or not we're really doing a fast speed, slow speed, medium speed. But here's the point: when in doubt, slow it down. What slow speeds for your patient actually do? You know you have better patient education because you're going to be able to motor plan a little bit better. You don't want the oscillations. You don't want them having issues or discomfort associated. You want it to be slow and steady. You want them to have good motor control, meaning time to kind of get the feedback back so that they're loading appropriately. And we're really going to talk about this again next month when we get into eccentric and deceleration training with strengthening aspects and the components that we need to look for. So this month I wanted to kind of come back to some questions for you guys too. So what's the best position to start quadricep training for someone very weak? Is it full extension? Is it 10 to 20 degrees? Is it 30 degrees, 45, 60, 90 degrees? You know, what would you tell me if you just answered it right now, what your answer would be? And if you say something, here's the other thing that I want you to talk about. Where do we normally start all of our quad sets and our straight leg raises? Probably a full extension, right? But really, where is the quadricep as an ascending, descending curve? Where is it the strongest? Well, it's really strongest at about 60 degrees in the range of motion. That's where we can generate the greatest amount of tension. You know, if we talk about the cross bridges between our actin and myosin, and if we look at the testing that's been done isokinetically and isometrically through multiple points in the range of motion, we know 60 degrees typically is where the quadriceps generate the greatest amount of tension. So does it actually make sense for us that maybe we want to start at 60 degrees if we can, if they have the range of motion and they don't have any issues at that position, versus terminal extension where we know they're typically the weakest? Second part then is, what's the best position to start the hamstrings then? You know, I'm big in the hamstrings because we've been working with a lot of soccer players for a long period of time. We see a lot of hamstring strains with soccer, rugby players. I was big in rugby for a long period of time, and also our track athletes. So what's the best position? What would you tell me? Do we go back to full extension again? Do we talk 10, 20, 30, 45, 60 degrees, 90 degrees? And it's interesting because I've seen different things in literature that becomes important to us. So I've seen literature talk about 90 degrees because they put somebody in that position. But what's really interesting is when we go back and we look at human strength curves in Science and Sports Review, and we talk about the different curves. Not every muscle is an ascending, descending curve. Some of them are ascending curves, some of them are descending curves. Hamstrings happen to be a descending curve. They're strongest around 30 to 35 degrees in the range of motion. And that's what we're actually looking at when we do this test. It's not really an ascending, descending curve because they're really starting off without any tension. They're going up very quickly. But where they get the greatest amount of tension is typically between 30 and 35 degrees in the range of motion. So again, from our standpoint, where should we start loading someone that might have a dysfunction? Should it be where they're the strongest and they're able to recruit the most? Or should we put them at a weaker position and just have them kind of fail until they're able to achieve some type of stability? How many of us ever talk about an extension lag with our patients? We see it all the time. So again, when we talk about hamstrings, we talk about really it's a length tension relationship. And the main determinant of mechanical loading experienced by active muscle fibers is the force velocity curve. And we'll talk about that again next month and how important force velocity curve is. But again, the length tension relationships also play a role. And the key feature is that the length tension relationship is an extra force that can be exerted during muscular contractions when the passive elements are able to contribute, which occurs when the muscle is elongated to long lengths during normal strength training and also during eccentric training types of things. So the greater load on those passive structures is also mostly likely why conventional strength training involving long ranges of motion and isometric training at joint angles corresponding to long muscle lengths often cause greater hypertrophy than strength training involving partial range of motion or at short muscle lengths. So, you know, go back to the quadricep again. Are you in a shortened length at terminal extension or when you're at 60 degrees in the range of motion? And it's also why strength training involving long ranges of motion and isometric strength training at joint angles corresponding to long muscle lengths often cause greater muscle fiber length than other types of training. So it's important for us to remember the science behind the exercise and all of the components that we want to go to. So here are a couple of points that we often go over. If someone is very weak, we want to start them in the optimal position to recruit and then slowly expand 10 degrees in both directions if it's appropriate. But what we also have to ask ourselves as a treating therapist, what's important to the patient? And what I mentioned by that is, do they have recruitment issues? I mean, is this a neural adaptation issue where they just can't coordinate? They can't, really be able to even get a muscle control moving? Or are we just talking about pushing harder for force production? So again, with quadriceps, I like starting them isometrically at 60 degrees with minimum recruitment. I want to see that they're being able to hold that for a period of time. And I'll normally take them through 3 to 5 repetitions with a 3 to 5 time longer rest period in between. Once I have that, I'll expand it 10 degrees in either direction. So I'll go 50 degrees in the range of motion, 60 degrees, 70 degrees. So my start angle might be 70. My end angle is going to be 50 with a hold time of maybe 5 seconds with 15-second rest in between contractions. I want to make sure that I'm giving that patient enough time to kind of recover before they go on to the next point. And I'm not making this a real painful or difficult exercise. And I expand the range of motion as the patient improves to include additional points in the range of motion. We all remember, science used to tell us that isometric kind of makes us stronger, plus or minus 5 degrees in either direction. And, research actually has kind of shared that with us for a long period of time. But if you look at newer research, it also says that by training at those longer muscle lengths, so if we go to 60 degrees, we actually get improved force production further out than 5, 10, 15, 20 degrees in our range of motion. So it's important for us to kind of pay attention to the science behind the exercise. So again, what's important to the patient? Do they have a recruitment issue? We've got to come back and kind of analyze that neural adaptation. Maybe we start on a very gentle passive range of motion to get that range of motion, and then that eccentric unloading. And we have to remember that endurance is just as important, if not more so sometimes, than just force or strength production, especially when we talk about some of our older patients. And I know in the past that we've kind of brought most of our rehab training on this webinar back to ACLs and some of those others, but I really want to kind of push the point that we all have significantly more osteoarthritis patients out there than we're ever going to have ACLs. So think how many patients we would be able to benefit from the treatment processes that we have if we could always reach them. So again, how well do they maintain that force? Over how high do they push? And then my last little point, whenever I talk lower extremities, so just not knees, ankles, hips, even trunk, even back, pelvis, what about balance? How important is balance? Now, what's interesting, and I do a whole program on balance, and if you're interested in that, please let us know. I'll be happy to do our balance program for you. But you know that by improving lower extremity strength, you improve balance. But balance also it's a multifunctional progression. It's not just lower extremity strength alone that's going to improve our balance. We need to bring all the other components in. So again, that's my point. I want us to think not just ACLs, but think older adults, neural adaptation, proprioception, and how many patients are we missing that can benefit from what we offer. And so with that, I'm going to throw this to you. How do you guys test balance? Or do you test balance? Almost all of us train balance, but do you test? Do you do a CTSIB test? Are there testing mechanisms that you have that are reproducible that you could give me that information back and forth for each month that we're doing those tests? Because I think that's important to us also. So research is important, but here's what's just as important to us. Are we listening to our patients, and are we helping them with the aspects that they're concerned about. So early in my career, and I love to use myself as an example of doing something wrong, I knew how important exercise was, and I knew how important my joint mobilization and my manual therapy was going to be, and all the other things that I had for this. And I was like, don't worry about pain. Pain will come, pain will go. As we get you stronger, it's going to go away. But you know, some patients just didn't want to hear that. They're paying attention to pain. And in today's world, especially with the opioid epidemic that we're having, pain becomes something that all of us as physical therapists, occupational therapists, rehab specialists need to really kind of pay attention to. So when they did an experimental knee pain, they actually injected into the infrapatellar fat pad a hypertonic saline solution to kind of generate acute joint pain. It resulted in impaired force steadiness affecting motor performance. And we know that. You know, somebody with a swollen knee, with an infused knee, especially in the suprapatellar pouch, it shuts down the quadriceps. You probably know it shuts down the VMO even faster than it does the rest of the knee. And the VMO is an A-terminal extensor. It's a medial patella stabilizer. So part of this for all of us as rehab specialists is we have to understand and we have to manage pain. And is there something that we can do in our exercise program that will allow us to help manage pain with a lot of the patients that we're doing? And again, benefit back to Danny, because he shared these with me a while ago. Isometric contractions. So from Clinical Journal of Sports Medicine in 2017, isometric contractions have a more analgesic effect than isotonic contractions for patella tendon pain, especially in season, as a randomized clinical study. And they also looked at, do isometric isotonic exercise program reduce pain? A randomized clinical study, and they found that both programs help to reduce pain, but isometric actually is less stressful in those aspects. So if we're not talking about an athlete, let's go back to that older patient and we irritate and aggravate that knee. How likely are they to want to come back and do that again? Then we might have to come back to 1 or 2 sessions and actually calm them down. So let's talk about how isometrics can actually produce a little less discomfort and actually improve the analgesic effect. And the other thing I'm really big on, and you'll hear me push this every single time we talk about exercise, is we really got to know about our motor control. It's got to be one of our first line of progression with our patients. So, you know, if you talk central control, that's the, you know, the imagined contraction, the visualization that we're doing, or the crossover effect. You know, you train one quadricep in order to get that crossover effect in the other. But when we talk peripheral, we're really talking about just that disinhibition. We want to reduce inhibition so that we can increase muscular force, and we want to make sure that agonist-antagonist co-activation is appropriate. You know, if we can decrease the antagonist, we'll see a better antagonist position. So there are things that we can all do in order to make it a little bit better. So rehabilitation needs to include the strengthening and fatiguing exercises at maximum and sub-maximal forces. We don't get to maximal until we're able to kind of climb that ladder from 10% to 20% to 50% and so on, going up the chain. But we know that any decrease in force and neuromuscular activation, positional sense, EMG torque relationships all have a fatigability effect for the quads. So when we talk about that, especially with our knee OA patients, are they more likely to fall? And that's where we get back to one of those components we talked about in the very beginning. We'll mention it again, SAID principle, specific adaptations to impose demands, meaning that if we have somebody that has a beginning stability issue, we don't want to put them on a high loading exercise program. We want to start them through a progression that will allow them to stabilize appropriately. So if we start with those patients that have gone through OA, and we know if they go long enough, they're going to end up with a total knee. And we all see a ton of total knees. So one of the things I love to do is I put them on the machine fairly early on the passive mode. We get them to increase their range of motion. We get great mobility terminal extension, we get them into flexion, we get them into that eccentric unloading principle where they start to slowly activate the quadricep to help lower the leg down. And then when we can see that they're doing eccentric loading correctly, we get them into the very gentle quadricep isometric stabilization, starting at 60 degrees and slowly increasing it as we go. What's interesting about this, though, is how do we actually kind of test and measure those patients to progress them with the TKAs? You know, how do you send back that information? Are you saying that, oh, they went from a 3+ to a 4? Or would it be better for us to say that they're able to generate, 40 pounds of pressure at this point in the range of motion, and 2 weeks later, they're able to generate 50 pounds, and 2 weeks after that, they're able to generate 60 pounds in an appropriate standpoint. So measuring our patients and our progressions become very important. And again, one of the conclusions, and I love using research that's just not from the United States, but internationally. So I kind of searched through Europe, I searched through Asia, and again, one of the things that they kind of looked at is that early on in the post total knee period, isometric quad testing may be preferable to isotonic testing because it's associated with lower knee pain intensity. And again, this is a 2018 article from Musculoskeletal Science Practice. So all of those things kind of come back to what are we doing and how are we progressing the patient correctly. So we also know as we age, and how many older geriatric patients might we have in our practice that could benefit from some type of stabilization and or strengthening program. It's not all about how hard and fast that you can push, but really teaching them how to control their muscle strength and their force production. So when we look at a meta-analysis in measuring isometric versus dynamic measurements of fatigue, does age matter? Really what they looked at is maximum power is more decreased after fatiguing task in older adults. And the assessment of fatigue, meaning that isometric just force one time versus power. So again, remember force is a physics problem. Force equals mass times acceleration. We then go into work, so it's really force over distance, and then power is work over time. So when we start to talk about being able to do this over and over again, we start to identify that there may be an age-related neuromuscular fatigue mechanism that's occurring. And then the takeaway point for this, and that's the reason that we have to look at research and read into it is, and this is important for us from a functional standpoint, is this specific to types of contractions that we might see? So for instance, do you ever talk to your patients and say, do you have problems with stairs? Because I used to do that all the time, but actually what I prefer to do is go, do you have problems going upstairs or going downstairs? If you got problems going upstairs, it's more of a concentric contraction. Problems going downstairs, it's more of an eccentric contraction. And that's really why I get into the SAID principle so much. I train for what's important for function. And again, this is one of the last ones to talk about because they talked about plyometrics versus isometric training, and plyometric deceleration training was better for performance type of stretch shortening cycle exercises. If we're going to get back onto the field and the other aspects, maybe isometrics isn't the best functional way. We need to go further, and then we have the tools to do that. So again, to me, when we talk rheumatoid arthritis, we talk spondyloarthritis, we talk knee and hip osteoarthritis, it's really important. And the World Health Organization made some great recommendations. And again, it's from the European League Against Rheumatism. In fact, when I was over in Europe a month ago, I was able to talk to several of the athletic trainers that were associated with World Health, and we were kind of teasing that was the what part of who. So what was the World Health athletic trainers who were helping to look at exercise intervention across the effects. And again, one of the things that they found is that intervention is extremely appropriate and effective for muscle strengthening in people with rheumatoid arthritis, osteoarthritis, and it's one of the cornerstones of things that we need to be able to get into, and that those exercise interventions are really important to us.
Hey, John, I'm sorry, but my feed went down. I don't know if it did for others too. Who did you say was responsible for that research?
Yes, Daniel, who was responsible?
Yeah, that's what I want to know. Who was it?
Exactly, who was responsible?
Well, yeah, that's what I'm trying to find out. Who generated the research?
That's right, who generated the research?
Who did?
Yes, who?
John, what are you talking about?
Well, what is something I was talking about because of who?
Who was what you were just talking about?
Yes, Daniel, who is what I was talking about?
What are you saying?
What says the research from who is important to everyone?
Who like what's research?
No, Daniel, what likes whose research? I think we all should.
Whose research is good?
Yes, exactly, whose research is very good.
That's what I'm trying to find out.
No, what do you need to know about who?
OMG, John.
Daniel, why are you bringing the orthopedic medical group into this?
What?
No, Daniel, who?
John, I don't know who you mean or what you're saying.
Daniel, read the research to get what has to say about who.
Okay, I'll read whose research.
You've got it. That's perfect. Thanks for clearing this up for everyone, Daniel.
I don't know who I cleared it up or what I did.
That's why you're teaching this course, Daniel, to clear up that kind of confusion. So guys, we hope that didn't throw you off too badly, but we just wanted to bring in a little comic relief. So here's the other aspect for us to pay attention to. How many of you actually have patients going through regenerative medicine? So the blood-based procedures such as PRP, stem cells. Well, but how do you know what you're supposed to be doing with those patients? So one of the things is research kind of answers some of those questions for us and tells us that both strengthening and balance-based exercises following interventional regeneration medicines is indicated as the best data in knee OA. So here's a question I have for all of us in private practice and settings that work with patients. If the patient is willing to pay cash for all of these regenerative medicine programs, aren't they equally willing to kind of put this whole thing together so once they finish with that PRP stem cells, that they get the right type of exercise that they really should need? And then finally, I want to kind of finish this with really the kind of discussion about sports, because I know that's one of the things that most of us are interested in. So here's one: isometric strength of hip and knee muscles with injury risk in high school cross-country runners. And what they found is about 25% sustain an injury during the season. But the runners with the weakest hip abductors, knee extensors, and flexors had a significantly higher incidence of anterior knee pain. But shin injuries weren't as associated with that hip and knee strength significantly. So my question might be to you is, what's your takeaway from this? Instead of me telling you what I think always occurs, what's your takeaway? So the hip influences the knee. Does it influence further down, or is that from the ground up? And are they both important for us to pay attention to? And then finally, we all know about Throwers 10 exercise program. It's been around for a long period of time, and the advanced Throwers 10, we kind of expand upon that. We call ours the Throwers 25. And really what this talked about, and great article, Tim Ull out of Kentucky does a great job with research. What they wanted to look at is there a way that we could facilitate greater increases in muscle and strength over isotonic scapular plane abduction exercises? And what they found is that actually both training approaches increase strength and endurance, indicating that either approach will have a positive effect. So what they were looking at is when we're in that shoulder abductor scapular plane position, isometric and or isotonic exercises are both beneficial. So we need to be able to use those appropriately. So in our patient population, I love to set up a variety of different exercises. I take them through prone. It allows for distraction at 90 degrees in the range of motion, better scapular position for stabilization. It also allows us to kind of work that glenohumeral scapular platform if we need to with the ASTEM program. We do a lot of our sports athletes starting in this position to kind of get them into the next position that we need them to. Once we're able to return that range of motion and we have them stable in the straight planes, I want to get into a scapular position that really is going to work our rotator cuff. My scapular position is, again, that scapular plane, 45, 55 degrees of abduction with 30 degrees of horizontal adduction. And I'm going to work that humerus is in the plane with the scapula. And it's a great position for rotator cuff strengthening. So we do a series of isometrics associated with that. So here's another question I'm going to pose back to you guys. What position is best for knee? Is it sitting? Is it supine? Is prone even better for us than just into a sitting position? I think we kind of get used to sitting. It's an easy way of being able to do that, and they can see the screen and everything along those lines. But are there other positions that we might need to be able to get our patients into in order to make it a little bit more effective? And then how about visual feedback? Because I think this becomes really important to us, not only to you, but to the patient also. One of the things that you can kind of see is that one thing that we did is, instead of just having the monitor, we actually mounted a large screen on the wall and kind of tied it in together. So the patient's looking at the smaller screen, but we can be on the other side of the room or across, and we can actually pay attention to how well that patient is performing that exercise and monitor that patient, even if we might be talking with someone else for just a brief period of time. Visual biofeedback, to me, extremely important. And one of the advantages that we have, we're starting stability exercises isometrically early on. I'm a big hamstring guy. There's no doubt. We do a lot of stuff in sitting positions also, but how about prone? I mean, Dave Perrin, who I think is great, Teddy Worrell, did one on effects of body position on hamstring muscle group average torque. Suggests that prone may be actually a more advantageous position because it facilitates optimal torque production. I love getting into prone with a lot of our hamstring or even posterior hip pain patients. And again, ankles are another one. The lower extremity, the foot and ankle, is a big love of mine. I love working foot ankle. So we put a lot of our ankles on here. And it's one thing that I see that people don't do early on. So again, not just because they're the biggest, strongest guys get on here, but we put our older patients on here. How can you tell this is an older patient right off the bat? Because you're never going to get a young kid to walk into your clinic wearing that kind of shoe. That's how you know. But isometric stabilization early on in our rehab process, extremely important for us. So I'm going to invite Daniel to kind of come back in. And he put together a video that I think is fantastic on a lot of things that we've done. It's an important concept for all of us to pay attention to. So I'm going to play this for you. It's a great.
So now let's create a stored set of exercise. Click on Utilities at the top of the screen. From the drop-down menu, select Protocol Editor. In the Test Pattern drop-down menu, select Knee, Extension, Flexion. Here is a list of all saved testing protocols for this pattern. Click the dot next to Exercise. This is a list of all saved exercise protocols. Click the Add button to create a new protocol. Name the protocol Multi-Angle, Isometric, Quad, 10 to 70 degrees. Click the Add button to add your first set. This is the same screen you saw earlier in the dashboard. Select Isometric. Under Action, keep it on Extensors. For trial reps and rest, put both of these to 0. Under Set, select 3 repetitions, with a 10-second rest. Set the angle to 10 degrees. Keep contraction time at 5 seconds, but change rep rest to 10 seconds. Place the torque threshold to 1 foot-pound. Click the box, Computer moves patient to next angle. You don't need to adjust any of the settings on the far right, but go down to the bottom and click on the feedback button. Keep this set to torque versus time, but I wanted you to see the options available. If you have questions about any of the settings, click on the Help button. Click OK to finish. You can now see that the first set has been created. Click the Add button to write the second set. One of the nice features of the software is that the settings are carried over from the first set. All we have to do is change the angle to 20 degrees. Now let's just continue adding sets. Create one set for every 10 degrees of the range of motion. With this protocol, we start the quadricep in a shortened position at 10 degrees and it slowly lengthens as it progresses to 70 degrees. On the final set, change the angle to 70 degrees and also change the set rest to 0 degrees. Here you can see all the sets that you created. Click OK to exit. In the protocol name box, you can see the protocol you just created with the details listed at the bottom. And that's how easy it is to create a protocol. Click the OK button to exit. Now that we've created our set of exercise, let's run our patient through it. First, click on the Patient button and select your patient. If you look across the top of the screen, you can see your patient's name. You also have options available that you didn't before. Click on the Exercise button. This brings you to the pattern selection screen. Select Knee Extension Flexion without a specifier. This is the protocol selection screen. Click on the drop-down box and select Multi-Angle Isometrics. You have the option to add a set, edit, delete, duplicate, or change the order of the sets, but let's keep it as it is. This is the main exercise screen. After you select right or left, you can either click Single Set to run a specific angle, or you can click All Sets to run all angles. If you click the Set AZ button, this will set up the anatomic zero and range of motion without starting the set. If you click Single Set or All Sets, you will automatically be prompted to set the anatomic zero and range of motion anyway. When the exercise is complete, you can click on the Preview button to see a report. The next button is Edit Sets. I'll come back to this after the exercise to show you its features. Click the option Display Targets and freeze display if outside of target. When you're ready, click All Sets. This brings you to the same setup screen that you saw on the dashboard. My patient is already set up, but what I'm doing is sliding the pad proximally on the tibia. With proximal pad placement, this negates anterior shear and stress on the ACL. Because open kinetic chain exercise early in the rehab process has been controversial in the past, I've included 3 research articles that I want to cover. The top 2 articles look at anterior shearing using an anti-shear device, a proximally placed pad, and a standard distal placement. They found that using an anti-shear device or with a proximally placed pad, anterior shearing is negated. The bottom article is a systematic review of open versus closed kinetic exercise during ACL rehab. They recommend the use of both open and closed kinetic exercise in the interventions for ACL deficient or reconstructed knees. Next, we're prompted to set anatomic zero in range of motion. Our patient has regained full range of motion, so let's set anatomic zero to 0 degrees. When setting the range of motion, you need to have 10 degrees before the first angle and 10 degrees after the last angle. Since the patient is exercising from 10 to 70, the range of motion needs to be set from 0 to 80 degrees. Once the range of motion is set, the mechanical stops are indicated. This is the most important part of patient setup. Set your mechanical stops, and then you can click Set ROM. Once that's clicked, you can now click OK at the bottom of the screen to start the exercise. The dynamometer will automatically move to the first angle. This is the main exercise screen. The 2 purple lines indicate the targets we clicked earlier. They're currently set for 1 to 5 foot-pounds. Cue the patient to gently press into the pad and hold tension until the line travels all the way to the other side of the screen. Contraction time is set for 5 seconds and rest time is set for 10 seconds. Tell your patient to keep their torque line within the targets and ask them if they're having pain during the exercise. Let's pause the video so I can go over the visual feedback. Reps and sets are indicated in the top center of the screen. The patient is getting ready to perform the 3rd repetition of the first set. The y-axis is torque and the x-axis is time. At the bottom of the screen, you can see the current angle. At the top right, you can see the remaining contraction time. Above the time is the dynamometer status, which gives us the real-time speed, angle, and torque. Because the patient is resting, the torque indicates the weight of the limb, adapter, and pad. It currently reads 15 foot-pounds. In the top left is the peak torque and work of the set. Currently, the peak torque is 4 foot-pounds. If you add the peak torque to the weight of the limb, adapter, and pad, that tells you that the quadriceps has contracted up to 19 foot-pounds. Next, I'm having the patient demonstrate what happens if they push above or fall below the target limits. The display is stopped unless they stay within the limitations. I paused the screen again to show you a few more items. The real-time torque is always listed above the torque line. This can also be found in the dyna status. Here it's listed as -2. The negative simply indicates the direction of torque and does not indicate that the patient isn't producing tension. If you remember earlier, when the patient was resting, the dyna status read 15 foot-pounds. That means the patient pressed with 15 foot-pounds to overcome the weight of the limb, adapter, and pad, and is now producing an additional 2 foot-pounds for a total of 17 foot-pounds of tension. After the 3rd rep is complete, have your patient relax completely as the dynamometer will move them to the next angle. Again, cue your patient to gently press into the pad and hold tension until the line reaches the end of the screen. This will continue until your patient has completed all sets of the exercise. So here I'm checking with the patient to find out if he's having any pain, and he tells me that everything's feeling good. After the third rep, tell them the machine will move to the next angle. Now that the knee is more flexed, the quad can produce more torque, so let's adjust the targets for between 5 and 10 foot-pounds. Next, I want to show you strategies for if a patient has pain. Most likely, this is patellofemoral pain and is specific to the angle that they're contracting. One thing you can do is adjust the targets. It might be that the torque demands are too high. Here the patient is contracting again, but tells me that they still have pain. Go to the bottom of the screen and hit the cancel button. This will bring you back to the main exercise setup screen. If you look at the fourth set down, you can see that it has written error. Highlight that set and then click on the edit button at the top. In the edit screen, change the set for 0 reps and 0 rest. When you click the All Sets button, you get a warning saying that the existing data will be overwritten. Click Yes to continue. You will automatically move to the next angle. Here the patient tells me they are pain-free again. You may need to eliminate more than one angle. Later on in the presentation, I'll show you how you can tilt the dynamometer to resolve patellofemoral pain. Let's fast forward to the end of the 7th set. This is the last repetition of the last set. Once it's finished, it'll bring you back to the exercise setup screen. If this is the only set for the patient, click OK and take them off the machine. If you want to run the protocol again, you can give them a few minutes rest, highlight the first set, and then click All Sets to restart.
So as you can see, that was a great video, and a lot of people have been asking us, is there something I can kind of come back to kind of go through start to finish one of those aspects? And Danny put that together for you guys, and I think he did a fantastic job. So I want to make sure that we give a lot of credit back to Danny, because
And John, that's just one example. You can set your protocols, if you want to do 90, 60, 30, or run them from 40 to 90 degrees, like immediate post-op ACL. The reason why I like creating that protocol all the way through the range of motion, because I can click single set, start them right at 60 degrees, and then expand beyond. So I have everything right in one place.
And that's why we really want to do these webinars, to kind of show that the information that people don't have, that you have kind of brought forward for it. And that's why I kind of brought this slide up. How many of you guys know the story about Jim Thorpe? He was one of our gold medal winners in the 1912 Olympics. But did you know how he won his gold medals? The morning of his race, someone had stolen his shoes. So what he had to do is he had to go out and try to find shoes. And what he found is he found some shoes that people had thrown away. He found the left shoe that was one side, the right shoe that was the other. In fact, that's why you see two different socks, because he had to actually wear a couple extra socks in order for the shoe to fit. Now, it wasn't about the shoes. It wasn't the shoes that made him the winner. It's what he did with those shoes that matters. And just what Daniel kind of taught us, it's what you do with the machine that's going to matter to those patients. And so that's why you probably have seen that we kind of tease back and forth on Star Wars. Danny's a big Star Wars time to go from a stormtrooper, there's a million of them, to the master. And in case you didn't know, Yoda's last name is Lehiho. Can you say that all together one time, Daniel? Yoda's first name and last name
That'll
together.
be Yoda Lehiho.
That's right. You got it.
Okay.
So, any questions that you guys have? I know Daniel had one sent in to us.
Yes, John. So one that was asked to me was first with isometric stabilization training, what kind of torque should we expect or tension should we expect to see from like a knee versus say a shoulder?
Well, again, of course, depending on the person's size, the patient is specific to the patient. And that's the beautiful part about it, is that we all know it should be specific to the patient. So if we have a 120-pound female who might be a little older on that, I'm not going to expect much. I'm going to keep it in the early aspects of 3 to 5 degrees. If I have a bigger, stronger athlete on there who isn't post-surgery, who can produce a little bit more force, I'm going to allow them to be able to do that, but I'm going to go off of what their effort is. And so the first thing I'm going to look at is just 25% of their effort, and I want to be able to equate what force measurement they're giving us, just like you taught us to. So I can figure out what 25% of their effort is, and then I can kind of manipulate back and forth from that standpoint to make it appropriate for that patient.
Fantastic. One question I've been getting a lot through email is how can we convince some of our ortho surgeons and doctors who are skeptical about isokinetics? How can we convince them that what we're doing is safe, beneficial, and effective?
It really comes back to research. I mean, Isokinetics has a long-term aspect in regards to research, and especially the way that we apply it in today's world is a little bit more appropriate. So when we talk about taking them through the modes of rehabilitation, we can do passive range, isometric, we can do isokinetic for strengthening, we can do isotonic for control aspects, and then we can take them into functional training programs and monitor how well they're generating force in that range of motion effectively, both isometrically, concentrically, and eccentrically. Want to know what scares me? What scares me is taking someone into a single leg hop test that you have no clue whether or not they can generate appropriate force eccentrically. That's what scares me.
Yeah. One thing to throw in on top of that is if you can, invite your docs into the clinic. You can either, do an in-service right there, one-on-one with them, put them on the machine, let them see what passive feels like, eccentric unloading, the multi-angle isometrics, beginning eccentric, and then take them through some of those progressions. You don't need to run them through 3 sets of 10. Kind of throw in, different steps along the way so they know what it feels like. They have a misconception that what we're doing is still high speed, back and forth, concentric loading. So bring them into the clinic. If you can bring them in with a patient so they can see right there with a patient who is going through it, that can really change their minds. Definitely bring in the research, but I think that hands-on in-service can really help out.
I agree 100%, Daniel. Hey, thanks guys for listening tonight. We hope that this was worthwhile to you. Remember that you can always come back and review any of the information that we had, but especially go back into that video that Daniel produced, which I think was just so fantastic for beginning users.
Johnny, Daniel, thank you. You've done a great job tonight, and I hope we see you all in 4 weeks, the third Thursday of the month. Have a good night.
Fantastic. Thanks, guys. Take care. Bye.